so much for joining Cafe University and for our talk on considerations for temperature in public health studies. We're so excited to have two members from our Cafe data management team. Both of our speakers are Lauren Mock and Shreya Nalluri, who are at the Harvard T.H. Chan School of Public Health. I'm going to go ahead and pass it over to you guys, and you can get started.
Great, thanks, Nick. Hi, everyone. Thanks for joining us. Today, we're going to discuss considerations for temperature in public health studies. And so the motivation for this webinar is one, extreme temperature events, both heat and cold, are increasingly recognized as major public health risks. And it's well known that temperature affects cardiovascular, respiratory, and other health outcomes. And so it's important when assessing the impacts of these exposures on health to accurately do so, particularly when we're working with epidemiological studies, risk prediction, and public health planning. And so, as I said, both extreme heat and extreme cold can cause negative health outcomes. Exposure to extreme heat can cause dehydration, heat cramps, heat stroke, and worsened pre-existing chronic conditions. And exposure to extreme cold can cause frostbite, hypothermia, increased cardiovascular strain, and respiratory and immune issues. And so with an interest in studying the impacts of temperature on health, there are a few aspects that we need to consider. And today we're going to talk about four of those. So we'll cover how to define a temperature exposure, how to select a temperature data set, how to link temperature and health data, and finally, what to consider when you're actually conducting an analysis.
So as Shreya said, our first topic will be how to define a temperature exposure. And so to put this in context, some example research questions you might be interested in answering could be, is heat associated with heart attack? Is cold associated with hospitalizations for asthma? Or what is the relationship between temperature and mortality? And I just want to note that we'll be focusing on the short-term effects of temperature, which is studied a lot more commonly, although there are studies of the long-term effects as well. And so to make this a bit more concrete, here's an example of what your health data set might look like. So here we have 4 different individuals. We know the zip code in which they live. We know the date on which they're hospitalized. And then our question is, what temperature exposure do we want to link to each hospitalization? And just as a reminder, unless the individuals in our data set were wearing personal temperature monitors, we don't know what temperature they actually experienced. And so their personal exposure will be determined by how much time they spend inside versus outside, how much time they spend in different areas, for example, for work or for school, and also if they have access to air conditioning and heat when inside. And so usually we're using outdoor temperature as a proxy for personal exposure since it's not available. And another reminder that you're probably already familiar with from your own personal experience is that there are many variables that affect how we experience different temperatures. And so instead of just using what we would read on a thermometer, there are different heat metrics that capture different variables. And so the first question is, which heat metric do you want to use in your analysis? And so we'll walk through a few options first. So here we have land surface temperature, and this is measured from satellites. It's a measurement of radiant heat coming from the Earth's surface. And so this metric is useful for identifying hot surfaces and urban heat islands, but it's not a good approximation for what we actually experience on the ground. Next, we have air temperature. This is what a thermometer would read in the shade. It's really commonly used in health studies because it's so easy to measure and it's also widely available. But like we said on the last slide, there are many variables that contribute to our perception of temperature, and this doesn't capture those. Next, we have heat index. This is also commonly used in health studies, again, because it's so easy to measure since it only requires one additional variable, which is humidity. But again, it's excluding a lot of other variables that we know are also important. And I also wanted to note that this is not intended to be used for studies of cold stress. Next, we have wet bulb globe temperature, or WBGT. This was developed by the US military to assess the safety of training outside. And so it incorporates two additional variables, solar radiation and wind. And lastly, we have the Universal Thermal Comfort Index, or UTCI. This is different from all the other metrics in that it actually incorporates a physiological, a physiological model of how the human body responds to different temperatures. And so it incorporates even more variables, and it also requires additional assumptions about the clothing and activity levels of people in different conditions. And so even though air temperature and heat index are used most commonly, these last two metrics incorporate a lot more variables that we know are important for determining how we perceive different temperatures. And once we choose our heat metric, we can also think about choosing the timing of our temperature exposure relative to our outcome. So for example, if we have a hospitalization, we could choose our temperature exposure to be the temperature on the day of the hospitalization. We could look at temperature on the day before the hospitalization. We could do some kind of average over multiple days. Or we could even define some binary indicator for whether or not the hospitalization occurred during a heat wave. And so the choice of which timing you want to use will depend on the event you're studying, the outcome of interest, and also your research question. And once we decide on that, we can also think about choosing a daily metric. So of course, temperature fluctuates throughout the day. And so if we want to assign a single value to a given day, we could look at the daily maximum, the daily minimum, the mean, or the diurnal range. And so again, this choice will depend on your research question of interest. We can also think about taking these heat metric values and converting them to percentiles to standardize across regions and climate types. So for example, if we take 93 degrees Fahrenheit, that might be the 99th percentile of the temperature distribution in one climate, but only the 61st percentile of the distribution in a different climate. And the benefit of converting to percentiles is that we would capture this temperature adaptation, which we would expect to be different in these two climates. But the downside of this is that these percentiles might not capture the actual physiological response to 93 degrees Fahrenheit. And so lastly, do all these choices actually affect our modeling results? And so some researchers have investigated this question and drawn different conclusions. And so it seems to depend on the population and region of interest. So I've cited two papers here that have looked into this. And so I encourage you to check these out if you're interested in reading more.
So now Lauren has gone over the types of heat metrics that are useful when studying the impacts of temperature on health. But now we need to figure out where we can actually get that data from. So now I'll go into how we can actually select a temperature data set that's useful for your analysis. So here I'm highlighting four different data sets. These are common temperature data sets that are used often in epidemiological research. The first I'm going to talk about is ERA5. And here I've kind of highlighted two versions of ERA5. So we have ERA5, which covers the globe for both land and ocean. And we also have ERA5 land, which is more specific to land meteorological variables. And this is hourly meteorological data. And for the ERA5 land data set, we have it available at the 9 by 9 kilometer spatial resolution. And for the land and ocean data set, we have it available at the 31 by 31 kilometer resolution. And again, for the ERA5 data set, we have it from 1940 to the present. And for ERA5 land, we have it from 1950 to the present. And so the ERA5 dataset was developed by the European Center for Medium Range Weather Forecasts. And these are hourly estimates on atmospheric land and ocean climate variables. And ERA5 is a reanalysis, so it's combining outputs from multiple models with real-world observations to generate a more consistent and physically coherent climate data set. ERA5 has over 200 different atmospheric, land, and oceanic climate variables, but since we're discussing temperature today, I'm only going to highlight some of the key temperature-related variables, which include 2-meter temperature, 2-meter dew point temperature, skin temperature, 10-meter wind components, surface solar radiation, and surface thermal radiation. And so now, as Lauren discussed, using just these raw temperature metrics is not a great way to assess the physiological implications of extreme temperature. And so we can use the variables that are available in ERA5 to calculate these different derived heat metrics that more accurately represent the physiological effects of temperature. And so using the ERA5 variables, we can calculate heat index, wet bulb globe temperature, daily min, max, and mean temperature, and the daily diurnal range using the available variables. And ERA5 additionally has a pre-calculated data set for UTCI, the Universal Thermal Comfort Index, so that you don't have to go through the trouble of, working with a physiological model and working with your assumptions yourself. Next, I'll talk about the GridMet dataset. So this is daily meteorological data at the 4x4 kilometer spatial resolution for the contiguous US. And this is meteorological data that's available from 1979 to the present. Yep, and so this is daily 4-kilometer meteorological data that estimates temperature, precipitation, wind, radiation, and humidity for the contiguous US. And this reanalysis combines PRISM and NLDAS2 to again create a more spatially and temporally complete data set. And so this GridMet dataset is very useful when studying public health applications, particularly for the contiguous US that require a high spatial resolution. And again, highlighting the variables in GridMet, we have min and max temperature, precipitation accumulation, downward surface shortwave radiation, wind velocity, min and max relative humidity, and specific humidity. And unlike ERA5, we don't have the variables available to calculate wet bulb globe temperature and UTCI, but we can use the GridMet variables to calculate heat index, daily min, max, and mean temperature, and daily diurnal range using the min and max temperatures. And finally, we have the PRISM dataset. Again, this is meteorological data for the contiguous US. We have daily and monthly data available at either the 800 by 800 meter or 4x4 kilometer resolution. And the daily data is available from 1981 to the present. And interestingly, we also have monthly data available from 1895 to the present. And again, this is daily, monthly, and annual estimates of temperature, precipitation, and dew point at least the 4-kilometer resolution. And this data was developed by interpolating thousands of weather stations and combining that with elevation, terrain, and geographic context to create a more spatially continuous and GIS-ready data. And again, highlighting some of the variables in PRISM, we have min, max, and mean temperature, mean dew point temperature, precipitation, and min and max vapor pressure deficit. And similarly to GridMet, using the data available in PRISM, we're not able to calculate these thermal comfort indices like wet bulb globe temperature and universal thermal comfort index, but we can use the variables to calculate heat index, daily min, max, and mean temperature, and daily diurnal range. And so when thinking about what data set to choose for your analysis, it's important to weigh their strengths and limitations and understand how they can best be used. So with the ERA5, this is hourly data, so it can provide data on hourly extremes, and most importantly, it provides us with physiological heat metrics. But it's limited in that it has a coarser spatial resolution at 31 by 31 kilometers, which might smooth some local scale heterogeneity that could be important to you in some specific analyses. So this dataset is best used for global studies, if you're interested in hourly heat extremes, and particularly if you're interested in using those physiological heat metrics like wet bulb globe temperature and universal thermal comfort index. Looking at the ERA5 land dataset, we have a much higher spatial resolution on a global scale, but this only covers land. And this dataset provides more physically consistent variables and improved land surface processes. But of course, it's also limited because it's a land-only product, so it doesn't really represent any sort of ocean or ocean atmospheric interactions. And so this data set could be less suitable if you're interested specifically in island or coastal regions for your exposure studies. So this data set is best used when you're focused on land surface studies, if you're interested in some regional climate health applications that are outside of the US, since this does come at a higher resolution of 9 by 9 kilometers, and in general, if you're interested in global health studies. And then with GridMet, we have high spatial resolution daily data for the US. And importantly, this data set provides us information on humidity, but it's limited in that it is only daily data. So if you're interested in hourly extremes, this would not be applicable. And additionally, those physiological heat metrics cannot be calculated using GridMet data. So the GridMet data is best suited for US daily heat exposure studies and general environmental epidemiology applications to the US. And similarly, PRISM provides us with high spatial resolution daily data that is US focused, but additionally, it provides us with long-term exposure assessment with monthly data going back to 1895. But of course, it's limited in that we only have daily averages. It also has limited humidity and wind products. And again, we can't calculate those physiological heat indexes using the PRISM data. So this data set's best suited for, again, US daily heat exposure studies, long-term US exposure assessment, and general climate trend analyses. Additionally, when getting started with working with temperature data, there are some practical considerations to keep in mind as you get started. First off, high spatial resolution comes with trade-offs. So even when you're working with really fine resolution temperature data, it may not always capture some of those microscale heat effects or temperature effects that could be of interest to you, for example, like urban heat effects or other neighborhood scale information. Additionally, high spatial resolution substantially increases the computational storage cost and complexity when working with it. So it's important to consider that a higher spatial resolution might not always be appropriate for your analysis, depending on your computational needs and how fine-grained your analysis will be. Additionally, there are some biases, uncertainty, and missingness considerations to just keep in mind as you work. Obviously, these are things that can't be avoided, but they may impact some of your analysis down the line. So they're just something to keep in mind. One, gridded products can inherit biases from all of the models and the station physical data that they're using to create these data products. Urban and coastal regions are often undervalidated. And in the case of missing days or temporal smoothing, they could sometimes impact the detection of some extremes. And finally, I just wanted to highlight some resources that are available through CAFE. So we have some data sets available on Harvard Dataverse under the CAFE collection. And these are data sets that provide spatially aggregated data for ERA5, GridMet, and PRISM. We've also developed tutorials that are available on GitHub that walk you through things like spatial aggregation, heat metric derivation, and population weighting. So highlighting a few of these resources, we have the GitHub tutorial on querying the ERA5 land data. So we walk you through how to download the data from the Copernicus Climate Data Store, and then we walk you through how to derive the heat index and humidex metrics from the ERA5 land hourly data. And finally, we provide an example on performing spatial aggregations to administrative boundaries. And in this case, we use Kenya as an example of that. And we also have a Dataverse deposit. This is the data set that is generated using the pipeline from the GitHub tutorial. And so this is available as well on the CAFE collection on Harvard Dataverse. For GridMet, we have county and ZICTA aggregated US GridMet variables available on Harvard Dataverse. And these were developed by members of the NSAF team. We've also developed another GitHub tutorial on population weighting, and I will discuss population weighting in the next section, but just pointing out that we have this GitHub tutorial available that walks you through, again, how to work with some of this gridded meteorological data. And specifically in this instance, We're using PRISM data as an example on how to perform population weighting, but this GitHub resource can easily be adapted to use for other gridded meteorological data. And again, the output of that pipeline is deposited on Harvard Dataverse under our Café collection for you to take a look at. And finally, I wanted to highlight a kind of unique resource. This is a Dataverse deposit, again, under the Café collection, and this provides spatially aggregated monthly and annual meteorological data coming from multiple different sources. So we have things like GridMet and PRISM included, but there's also some other sources for which they've provided aggregated data, such as Cope and Geiger, CDAC, and et cetera. And so now that we have an idea of the types of data sources that are available to us, we can finally get started with figuring out how to actually use the data to prepare it for our health studies. So as a reminder, when working with health data, our health data is generally available to us at an administrative boundary level. So we have things like information about zip code or county available for each individual. But we have temperature available at a gridded level. So we have daily gridded temperature data. And so when we want to figure out how to map temperature to a date of exposure, we have to figure out how we can convert this gridded data into an administrative boundary. And so again, our goal here is to figure out how we can convert the daily gridded level temperature data to daily zip code level temperature data. And so this can be done by mapping the grids to administrative boundaries. So here we overlay the gridded meteorological data onto the administrative boundaries, and then we use area-weighted averages in the case when the meteorological gridded data partially overlaps with administrative boundaries. And so delving into that a little more, the problem here is that most meteorological data sets like GridMet, PRISM, or ERA5 are reported on these continuous regular grids, but our health outcome data like hospitalization is reported at an administrative boundary level. And so we need to figure out how to get these grids to align with the administrative boundaries, but unfortunately, they rarely perfectly align with the irregular polygons of the administrative boundaries. So while we can overlay the grids onto the polygons, we need to account for these instances of partial overlaps by computing area-weighted averages. And so here's kind of an illustration of this. So on the left, we have polygons of Delaware watersheds, and we want to map the daily maximum temperature to each of these polygons. So in the middle, we have the gridded daily maximum temperature from GridMet. If we were to overlap these the gridded data onto the polygons, we would see that some of the polygons would overlap with the grids 100%, but there would be some grids that only partially overlap with each of these polygons. So if we were to just average the grid cells that just touch one of these polygons, we would treat each grid cell as equally important, even if only a small portion of the grid is actually inside the polygon. So by using area weighting, we can weight each grid cell by the fraction of the area that actually lies within the polygon. And so the grid cells that mostly fall inside the polygon would get more weight, and the grids that barely overlap with the polygon would get very little weight, which would give us an average temperature that more truly represents the geographic area of the county and wouldn't be as skewed by the shape of the grids and the size of the grids themselves. And so in doing so, we finally get a mean daily maximum temperature for each of these Delaware watersheds. And so this first step is the most important in getting your temperature data into a format that can actually be used with your health data. But there are some additional steps that allow us to transform our temperature data into something that can be more physiologically relevant and more useful for our health outcome research. And so the second step is applying population weighting. And here we want to weight the exposure, such as extreme temperature, by population to estimate a more population relevant temperature metric. And so delving into the problem a little more here, people are not uniformly distributed within a county or zip code. And so basing exposure on area alone might actually misrepresent the actual exposure that people living there experience. For example, if we have a county that by area is 50% mountainous and cool and 50% urban and warm, if we were to solely base the mean temperature of that county by area, we might underestimate the temperature that individuals actually experience, since only 10% of the population of people live in that cool mountainous region, while 90% of the population lives in the warmer, more urban region. So by applying population weighting, we can estimate a more accurate representation of the temperature that most of the individuals in that geographic location are actually experiencing, and thereby providing a more physiologically relevant temperature metric. So after we've completed the population weighting, we can go on to create our analytic metrics. And so, as I mentioned before, the raw temperature is not super useful when we're working with studying health outcomes. It's not very interpretable for health because raw temperature doesn't provide any physiological relevance in terms of the physiological impacts of some of the extreme temperature events. And in addition to that, if we're interested in extreme events like heat waves, these thresholds are not obvious when just looking at the raw data. So we need to derive metrics, as Lauren mentioned before, for things like daily min, daily max, heat index, or thermal comfort indices. When interested in some of these more extreme days, we can use relative thresholds like percentile to derive an analytic exposure metric that is more useful for our analysis. And just a reminder that we have GitHub tutorials available on how to perform steps 1 through 3, essentially. So we have that tutorial on using the ERA5 land data to perform the spatial aggregation and derive heat metrics. And we also have the PRISM GitHub tutorial that walks you through how to perform population weighting on gridded meteorological data. So finally, we've prepared our temperature data to be in a format and in a more useful form to merge with the health data. And so now we can finally do so by merging by date and location. So again, here we've converted our gridded temperature data to zip code level daily temperature data, and we have our health data available to us at the daily zip code level. So now all we need to do is merge by zip code and date to get a temperature and health data set. And so finally, once merged, we've mapped the max temperature for each date of hospitalization, and now it's finally ready to be used for analysis. Lauren, I think you're still muted.
Sorry, thank you, Shreya. I was just saying, oh, sorry, let me go back here. Now we have our data set ready, and here are some things that you want to consider in the analysis stage. And so we wanted to highlight the case crossover study design, which is really useful for studying temperature. And in this study design, we have individuals who experienced the event, and they serve as their own controls. And so, for example, if you want to study, is heat associated with heart attacks, you would consider only individuals who had a heart attack during the study period. And then for each individual, compare temperature exposures on the date of the heart attack versus on similar dates. So for example, if someone had a heart attack on July 13th, 2015, that would be our case date. And we would compare that to control dates, which could be all other Mondays in July 2015. And some strengths of this method are that it inherently controls for individual level variables that are either constant or very slowly over time, such as diet, which you wouldn't expect to change much throughout a single month. And it's also computationally efficient because it includes only individuals who experience the event. But some limitations are that you need to be very careful with control selection, how you choose those control dates, because inappropriate selection of these controls can bias the results. And also, since we're only looking at individuals who did experience the event, sometimes it's more difficult to generalize to the broader population. We also wanted to highlight a method that can be really useful in this setting, which is distributed lag nonlinear models, or DLNM. This method allows you to incorporate lagged exposure effects. So, for example, daily temperature exposures over time. And it also allows for a nonlinear relationship between the exposure and the response. And so, for example, if you wanted to study the relationship between temperature and daily mortality counts in New York, you could use a DLNM to produce a plot that looks something like this, where you get this surface of relative risk of mortality. And the two axes we have down here are temperature and also lag, which is telling us the amount of time between the exposure and the outcome. So, for example, a lag of 10 means we're looking at the effect of temperature 10 days before we're assessing mortality counts. And so we can investigate some really interesting questions with these kinds of models. And as you could see in that last figure, and also these three additional figures, the relationship between temperature and health outcomes is typically nonlinear, even if you're only looking at the warm season, for example. And so it's really important to choose a method that allows for this nonlinear relationship. You also might be thinking about confounding. And so, of course, temperature varies seasonally, and health outcomes also vary seasonally, which you can see in this plot of daily mortality counts over time. And so it's important to control for this seasonality. And there are a few different ways to do this, but one is to use a spline term to capture these long-term trends that occur in health outcomes. And you can see that spline plotted here. And this allows us to focus on these short-term differences in the health outcome. And I just wanted to note, since I did highlight case crossover studies, that we don't need to account for long-term trends in this way for a case crossover study design. But what we do to minimize confounding is appropriate selection of the control dates. You also might be thinking about air pollution and wondering if air pollution confounds the effect of temperature on health. And so the relationships between temperature, air pollution, and health is quite complex. And several studies have found that adjusting for air pollution does change effect estimates of temperature. And so it is common to adjust for air pollution in temperature studies, but is it appropriate? And so there's this nice paper, Buckley et al., that discusses four potential DAGs, or directed acyclic graphs, which I showed here. And the authors concluded that adjusting for air pollution is typically not justified, although it does depend. And so if you're interested in reading more, I highly recommend looking into this paper, since these relationships are complex. So that concludes our presentation. Just to recap what we've covered today, we looked at how to define a temperature exposure by choosing a heat metric and the timing of the exposure. We looked at how to select a temperature data set, things to keep in mind, and highlighted some CAFE resources for you. We looked at linking temperature and health data, and also some things that you should consider when conducting an analysis. We want to thank the CAFE team for incredible feedback on this webinar. And here are our references, which will be available to you after the presentation. Thank you.
Thanks, Lauren and Shreya. That was awesome. I really loved your graphics. To the audience, I see some questions are already popping into the chat, but we'll do a little Q&A now with Lauren and Shreya. So please feel free to keep popping your questions into the chat. In the meantime, maybe I'll kick it off with a question. So I was wondering if you did a really great job, Lauren, covering nonlinearity and potential confounding of temperature. I was wondering if you could also say a few words about known effect modifiers of temperature that you might want to consider in your study.
Yeah, I think that gets complicated because air pollution can be considered an effect modifier, but also a confounder. And so there are a lot of meteorological variables that interact in complex ways. And so I think different people have different opinions on how to study them, to study the interactions, how to frame them. And so I think if you're doing a study like this, it's important to read more about the literature and what people who have studied a certain outcome have done and justify why you would adjust for something versus not. I think that's the key to be able to justify your decision because different people come to different conclusions.
Yeah, agree. I was also wondering, I noticed in some of the figures that you linked or were sort of showing from other studies, I think some of those other studies had sort of estimated effects of temperature totally separately across like cities or states, which is I think a fairly common practice, to sort of do analyses separately across some kind of region, cities, states, something like that. And then sometimes folks meta-analyze them. I was wondering if you guys have any thoughts on that approach versus kind of pooling everything together across locations when you do your analysis, or if you saw anything when you guys were reviewing literature about recommendations for that kind of thing.
Yeah, that's a really interesting question. That's not something that I explored much. I guess it would depend on the scale of your analysis. If you're trying to do like a full national analysis, it's not feasible to look at different cities separately. But as I mentioned, like the way that we adapt to temperatures in different places is very different. And so, like, what would be an extremely hot day in one city would be a normal day somewhere else. And so, there is like a huge benefit of being able to look at them separately, and the way that people respond to heat is going to be different in different places.
Yeah, agree. And even things like prevalence of air conditioning and things like that are so different across cities. Um,
Yeah.
yeah, makes perfect sense. So it looks like there are some questions popping up in the chat. Maybe I can bring up some of those. So Anand asks, is there a GitHub on case crossover or DLNM studies? And I think actually somebody in the later in the chat has responded saying that Antonio Gasparini has some really nice vignettes and code examples on this and linked to them. So thanks to those who responded. Yeah, I would agree that Antonio Gasparini is definitely the person to Google search if you're looking for resources on DLNMs specifically. He's also joined us for and given a cafe webinar on these types of methods. So if you go to the cafe YouTube site and scroll back through the history of our webinars, you can also watch the recording of the webinar that Antonio Gasparini gave that describes the resources his team has produced in more detail. A question from Win Lee, who says, if our cohort address, more coming in and it's scrolling up. If our cohort address is a detailed street level address rather than an administrative boundary, should we still take administrative boundaries into account? And is population weighting necessary? So I think that might be a question more for Shreya, and a really good one.
If you have your health data available to you at like a street level basis, I don't think there's any need for you to aggregate, say, to like the county or census tract or ZICTA level. And since these grid cells, say for like GridMet or Prism, are available at like a 4 by 4 kilometer grid, one grid would essentially map to like your street address probably. And so additionally, because you have like such high resolution health data, you probably wouldn't really need to weight by population as well, since you're only really using like one grid for each individual or like each street address, essentially.
Yeah, that definitely makes sense. Um, okay, great questions coming in. So Deborah asks, can anyone comment on the suitability of underlying gridded data and their spatial and temporal resolutions in the fitness for use calculation when trying to construct summary stats for any given administrative areas, and whether there are tools to assess this suitability? I don't know if you have any insights on sort of the general suitability of gridded temperature products for health studies, Shreya, from what you've read. Oh, I think you're still muted. Sorry.
I don't have like a robust answer for that in terms of like how like their fitness for use. But of course, some of the data products that they did present have been used extensively in health research. So, I mean, at least in terms of ERA5, and GridMat, PRISM, these are data sets that are used extensively in the community. So I think that at least speaks to their usability in health studies.
Thanks. Let's see, Juliana asks, I've seen some people working on revisions of the heat index, and she provides a link. She asks if you have any thoughts on calculating heat index, especially at very high temperatures.
Yeah, I always thought there was only one way to calculate heat index, but I learned there's actually many algorithms. Um, yeah, hmm. I did read that heat index was like some algorithms can overestimate the importance of humidity. So like of course like a humid hot climate feels hotter than a dry hot climate, but like there are different like points of strengths and weaknesses and like an extremely humid climate heat index might overestimate how that would feel. So, but again, people have studied this and it might not have a huge impact on model results. So there are many, many, many heat metrics to choose from. So I guess again, like if you can justify your choice and why you would choose something, there are also like different considerations for different climate types. So I was reading about tropical climate types being different. And for example, even like the correlation between max and min temperature is very different in a temperate versus tropical climate. And so like the choice of heat metric depends on which climate you're studying, which of course will depend on if you're doing like a localized analysis or a global analysis. There are different things to consider.
Yeah, super, super complex. Thanks, Lauren. Um, Macarena asks, I'm working on something similar in Chile, but we don't have the same data granularity regarding georeference as US zip codes. So I think maybe it sounds like this question is sort of asking for a comment on how reasonable it is to use um, area codes that are more coarse even than US zip codes for temperature studies.
Yeah, I've definitely seen it done before. For example, I have a coworker that works on data in Madagascar, and they use health sheds, which are much larger than U.S. counties and zip codes. And I think it's feasible. That's the best you can work with the health data that you have available to you. And in terms of the process of mapping your exposure data to your administrative boundary, it it doesn't change the process in doing so. So.
Right. My sense is that it could lead to a bit more noise in your results. So you could have sort of higher degrees of exposure misclassification, especially if you have things like urban heat islands that are very localized occurrences within these larger areas. You could potentially sort of smooth over those and uh, potentially eliminate some of the signal in the data that you might be looking for. But agree that if that's all you have, then I still think it'd be reasonable to look at this. I'm not seeing any more questions in the chat. So I think unless anything else pops up, I want to say thanks to you guys, Lauren and Shreya. This was incredibly informative. I see several questions coming into the chat about both the recordings and the slides. So we will make the recording available on the Cafe YouTube site sometime within the next week or two, probably. So you can look for it there, and then we'll also link to the slides in the description of the video. So thank you guys so much again. Getting lots of positive feedback from the chat. Folks saying how useful this was, and I agree, it was awesome. So thank you so much.